Lateral epicondylitis, also called tennis elbow.
Tennis elbow or lateral epicondylitis is a painful condition of the elbow caused by overuse or inflammation of the tendons of the common extensor origin. Overuse of the extensor carpi radialis brevis can cause microscopic tears in the tendon where it is attached to the lateral epicondyle, causing inflammation and pain on the elbow and weak grip strength.
Anatomy. Extensor muscles of the forearm. Insertion of the extensor carpi radialis brevis is involved. Lateral and medial epicondyles of the humerus. The radial nerve. The three bones of the elbow joint are the humerus, the radius, and the ulna. And lateral epicondylitis causes a bony bump on the lateral elbow. The wrist extensors involved are the extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi, extensor carpi ulnaris, extensor indicis, extensor pollicis longus, extensor pollicis brevis, and the abductor pollicis longus. All of these extensors originate off of the common extensor tendon. Pathology of lateral epicondylitis. It is a tendinopathy injury caused by inflammation, and it can cause microscopic tearing. It is usually a degenerative process causing hypovascularity, and it happens when contractile injuries that chronically stress the tendon near the attachment on the humerus may result in hyaline degeneration of the origin of the extensor tendon. Mostly occurs on the dominant arm. Deficient flexibility and strength in the wrist, extensor, and posterior shoulder muscles, and changes in biomechanical factors can cause it as well. Mechanism of injury includes contractile overload that chronically stresses the tendon near the attachment on the humerus, sports like baseball, swimming, and field throwing events, mostly common in work-related injuries that involve wrist extension, pronation, and supination, repetitive upper extremity activities including computer use, heavy lifting, and forceful arm pronation and supination. Signs and symptoms include inflammation, hypovascularity, radiating pain down the forearm as far as the wrist and the hand, difficulty with lifting and gripping objects, and symptoms usually last from 2 weeks to 2 years. Special tests include the dynamometer, which is a pinch gauge. It measures hand strength to eval dysfunction or trauma, the Cozens test, the Mills test, and the Maudsley's test.
Video on the Cozens test for lateral epicondylitis, better known as tennis elbow. Hi and welcome back to Physio Tutors. The Cozens test is designed to maximally flex and thus provoke the extensor carpi radialis longus and brevis. To conduct the test, have your patient in a comfortable position and stabilize his elbow while you palpate his lateral epicondyle with your thumb. Then ask your patient to make a fist, pronate his forearm and radially deviate, and extend the wrist while the examiner gives resistance. This test is positive if your patient complains about sudden pain. Video on Video on the Mills test for lateral epicondylitis, better known as tennis elbow. Hi and welcome back to Physio Tutors. The Mills test is designed to maximally stretch and therefore provoke the extensor carpi radialis longus and brevis. To perform the Mills test, have your patient in standing position and fixate the humerus while you palpate the lateral epicondyle. Then passively pronate your patient's forearm, flex the wrist and extend the elbow fully. This test is positive if your patient complains about sudden pain at the lateral epicondyle. Okay guys, this video on the going to show you a quick method to test for tennis elbow, also called lateral epicondylitis. Hi and welcome back to Physio Tutors. This method, that is unfortunately nameless, puts stress on the extensor digitorum that also originates from the lateral epicondyle. To perform the test, have your patient in a comfortable position, stabilize the humerus and palpate for the lateral epicondyle. Then ask your patient to pronate his forearm and then resist extension of the third digit of the hand distal to the proximal interphalangeal joint. This test is positive if your patient complains about sudden pain at the lateral epicondyle. Alright, this was going to show you
Predisposing factors of lateral epicondylitis includes both sexes, male and female, 30 to 50 years old, your occupation, depending on people who have jobs that involve repetitive overuse motions of the wrist and arms, and if you play any sports. Management and treatment. There are all kinds of therapies that you can use to help manage lateral epicondylitis, including surgical and non-surgical treatments as well. Surgical includes removing diseased bone and reattaching healthy muscle back to bone. This can be invasive and arthroscopic. And the non-surgical is just relieving pain and controlling swelling using braces or cortisone injections. Extracorporeal shockwave therapy. This is a method of treatment for multiple tendinopathies that can be used for the treatment of lateral epicondylitis. Patients are exposed to a strong mechanical wave impulse that can be used on a specific area. This has potential hemorrhage and local soft tissue damage, but this therapy offers a significant placebo effect. It is very similar to ultrasound. Deep transverse friction therapy is where connective tissue massage is applied precisely to the injured structures. The therapist tries to get an analgesic effect by applying constant pressure for about 10 minutes until a numbing effect has been reached. You have to have 48 hours in between sessions, and the purpose is to reduce damage and scarring caused by edema. The pain relief due to modulation of the nociceptive impulses, which are pain receptors, causes a better alignment of connective tissue, softens scar tissue, and blood flow increases. Eccentric exercises. Load increases ensures that the tendon has a greater stress and starts to progress. The speed on contractions is important, as the faster the contraction, the more load it has, and the tendon is stimulated more. And the frequency of contractions. 3 sets of 10 is normal and can be performed without overloading the joint. The greatest strengthening result is the elbow in full extension, forearm in pronation, and the whole arm is supported. Referral and immobilization. Refer to a physician or orthopedic physician for x-rays, MRIs, or EMGs, and you can also get a brace. Differential diagnosis includes radial tunnel syndrome, posterior interosseous syndrome, elbow osteoarthritis, fractures, cervical radiculopathy, cervical spondylolysis, fibromyalgia, and medial epicondylitis. Prevention: avoid overuse injuries, make sure your biomechanics are good, warm up and cool down appropriately. Mulligans: the patient is supine with arm by the side, elbow extended and forearm pronated. A lateral glide is applied to the radius and ulna with a belt around the therapist's shoulders. The patient then grips or extends the wrist against resistance as long as there is no pain. My PICOT analysis: my population was 87 patients, 54 patients with open procedures and 33 with arthroscopic. Arthroscopic procedures returned to work earlier and required less postoperative care than open procedures. 69% of open procedures and 72% of arthroscopic had good or excellent outcomes, and this was between 1997 and 2002. And there's my references.